All right, so aplastic anemia, this is going to result from an injury to or destruction of stem cells in the bone marrow or the bone marrow matrix, which can cause just overwhelming what we call pancytopenia. That means they have a deficiency in the red blood cells, the white blood cells, and the platelets, okay? And they can have bone marrow hypoplasia or underdevelopment. So we commonly use this interchangeably with other terms for bone marrow failure. Aplastic anemia is going to refer to pancytopenia resulting from decreased functional capacity of your bone marrow. Okay, so across the board, the bone marrow does not produce adequate red blood cells. But like I said, if they're not producing adequate red blood cells, they're probably not producing adequate white blood cells or platelets either. Okay. So mortality rate for this is very, very high. We're talking about mortality rate of 80 to 90%. And a lot of times death is going to result from bleeding or infection. So this can be caused from adverse drug reactions, for example. It can be exposure to toxic agents. It could be secondary to radiation, immunologic factors, severe disease like hepatitis. It could be congenital abnormalities. It could be a cause of, like I said, chemotherapy. It's usually the biggest one that I see with this is chemotherapy. Basically, it's designed to attack rapidly dividing cells, and that includes the bone marrow. So it's not uncommon for patients undergoing chemotherapy to experience aplastic anemia. So what are you going to look for? Okay, you're going to see the signs and symptoms of anemia. So you're going to see pallor, ecchymosis, petechia, potentially small hemorrhaging, weakness, fatigue, altered levels of consciousness, tachycardia. Sometimes your patients will develop a specific type of murmur. They may have a fever, oral, like ulcers of the mouth, okay? Sore throat, nausea. Again, you're gonna see any variety of anemia type symptoms, but again, you're gonna have issues with your white blood cells and your platelets, so there's also gonna be evidence of bleeding and high risk for infection because the white blood cells are also gonna be problematic. So diagnosis for this, your red blood cell tests are going to show your red blood cells of a normal size, shape, and color. You're going to look at, your CBC. You're going to look at an absolute reticulocyte count. Usually that's going to be very low here. We will look at a serum iron level. It's usually going to be elevated unless bleeding is occurring. But your total iron binding capacity is going to be normal or even slightly reduced. Your platelet levels, your WBC counts are going to fall. A lower platelet count is going to be reflected in your abnormal coagulation test, like your bleeding time. So you could also do those as well. They would also do a bone marrow biopsy from several sites because they want to see, is it one specific area? Are we dealing with, a wide variety of spots? And what you're going to see is you're going to see a depression in the red blood cell elements with your bone marrow biopsy. So effective treatment is going to be to eliminate the identifiable causes of anemia and provide vigorous supportive measures such as packed red blood cells, platelets, human leukocyte antigen matched leukocyte transfusions, and even then recovery is going to take months. Bone marrow transplantation is the preferred treatment of anemia stemming from severe aplasia and for patients needing constant red blood cell transfusions. Patients with low WBC counts may need interventions to avoid infection. They may be receiving antibiotics, but prophylactic use encourages resistant strains of organisms. So we're kind of careful with if we're looking at prophylactic antibiotics. Patients with low hemoglobin levels may need oxygen therapy and blood transfusions. Other treatments, sometimes you'll see bone marrow stimulating agents like androgens, but those are still pretty controversial. Immunosuppressants if the patient doesn't respond to other therapies. There's colony stimulating factors which encourage growth of specific cellular components in patients who have had chemotherapy or radiation therapy. Agents like granulocyte colony stimulating factor, erythropoietic stimulating factor. These are all things that you commonly see. And then there's also alternative and complementary therapies to treat the associated fatigue. Oh, sorry about that. Let me go back to that slide because there was other things I wanted to say. Oops. Okay, sorry about that. So if the patient's platelet count is below 20,000, you want to make sure you take steps to prevent any hemorrhage. So we're going to avoid IM injections, suggest that the patient use an electric razor and a soft toothbrush, humidify oxygen to prevent drying of the mucous membranes, and you want to promote regular bowel movements through stool softeners and a proper diet. You're also going to apply pressure to venipuncture sites until bleeding stops, and we're going to detect bleeding early by checking for blood in the urine and stools and assessing the skin for petechia. We're going to help prevent infection by performing hand hygiene thoroughly before entering the patient's room, making sure the patient eats a nutritious high diet and vitamins and proteins to boost resistance, and encourage meticulous mouth care. You want to make sure that there is routine throat, urine, and blood cultures to regularly check for any type of infection. We're going to watch for life-threatening hemorrhage, infection, adverse reactions, and transfusion reactions. We want to schedule frequent rest periods for a patient with a low hemoglobin level, administer oxygen therapy as needed and as ordered. If we're giving transfusions, we want to assess for transfusion reactions. We want to prevent aplastic anemia by monitoring blood drug levels carefully if the patient's receiving a drug that can cause anemia. So that's really common when you have patients undergoing like chemotherapy, for example, is they should get certain drug levels done, and we should be constantly on high alert for this. And you want to evaluate your patient. So the patient should experience fewer infections, blood cell counts should return to normal, the patient should breathe easier, and they should no longer experience trauma-induced hemorrhagic episodes. Those are our goals. And we want to make sure the patient and the family demonstrate knowledge of energy-saving strategies, okay? So we teach them to lump their care and to make sure that, when they're feeling tired and fatigued, that they take rests appropriately, okay? So that is going to wrap up aplastic anemia. The next lecture I'm going to do is going to be on sickle cell.